नमस्कार, आप सभी को बहुत बहुत स्वागत है इस सेशन में। आज हमारे साथ डॉक्टर दीप्ति गोडबोले।
हेलो।
बहुत स्वागत है हमारे साथ दीप्ति गोडबोले जी, जो बहुत ही अच्छा एक्सप्लेन करती हैं और बहुत ही अच्छा इनका एक्सपीरियंस है। तो मैं भगवान धन्वंतरी का वंदन करने के बाद मैं इनको आमंत्रित करूंगा कि ये सेशन को स्टार्ट करें।
नमामि धन्वन्तरिमादिदेवं सुरासुरैर्वन्दितपादपद्मं लोके जरामृत्युनाशं दातारनीशं विविधौषधीनां शङ्खं चक्रं जलौकां दधतं मृतघटं चारुतोर्भिश्चतुर्भिः सूक्ष्मस्वच्छादिरुद्यं शुकपरिविलसन् मौलिमं भोजनेत्रम् कालाम्बोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यम् वन्दे धन्वन्तरिं निखिलगदमिव प्रौढदावाग्निनीलम्।
नमस्कार, मैं दीप्ति जी आपको होस्ट बनाता हूं और मैं उम्मीद करता हूं बाकी सभी लोग अपना अपना माइक म्यूट रखेंगे। और दीप्ति जी का जब लेक्चर हो जाएगा मैं आऊँगा। मैंने आप सभी का माइक म्यूट कर दिया है और डॉक्टर दीप्ति जी मैंने आपको होस्ट बना दिया है। यू आर नाउ होस्ट ऑफ दिस सेशन, सो you can start your presentation, and after the presentation you can unmute and anybody can ask with the questions. Yeah, Dipti ji, aap host hai.
Sure. Namaste and good evening to everyone. So today I have chosen the topic, a very simple and a common topic, but still many things to learn in this topic, that is varicose veins. So whatever I know about this regarding the anatomical perspective and the surgical perspective, I'll just share some of my knowledge with you people. So let us start. I'll share the screen immediately. I hope you all can see the screen. Can you see the screen? Hello? Hello? Am I audible? Hello? Am I audible to you? Hello? Can you hear me?
Yes, Dipti ji, aap audible hai. You are audible. You are audible, and you just rotate the camera as you are host. So I have muted all of you.
Okay,
Yeah.
sir. Okay.
You can present
Got it.
yourself. And I think that because I have to join another session, so मैं आप में से किसी को होस्ट बनाता हूँ, क्योंकि दीप्ति जी यहाँ पे सेशन को चला रही हैं 1 मिनट। मैं यहाँ पे रमन गर्ग जी आपको होस्ट बना दूं, आप इस सेशन को एंड कर देंगे या फिर इस सेशन को कंटिन्यू चलाते रहेंगे? मीना नागर जी आपको होस्ट बना दूं? मीना नागर जी कौन बनेगा यहाँ पे होस्ट? उस सेशन एंड करना होगा फाइनली। चलिए रमन गर्ग जी आपको मैंने होस्ट बना दिया है। आप जब ये सेशन एंड हो जाएगा तो इनको वोट ऑफ थैंक्स दीजिएगा, और बाकी लोगों को आप जो है वो अगर कोई क्वेश्चंस होंगे तो आप अनम्यूट करते जाएंगे। ठीक है रमन जी, मैंने आपको होस्ट बना दिया है। रमन जी मेरी आवाज आ रही है आपको? आप होस्ट हैं इस सेशन के।
जी सर, थैंक यू।
अब आप इस सेशन को आप संचालित करेंगे। इनके लेक्चर होने के बाद किसी के प्रश्न होंगे तो आप ले लेंगे और बाद में सेशन को एंड कर देंगे। जी इनको वोट ऑफ
जी
थैंक्स
सर, थैंक यू, थैंक यू।
थैंक यू। दीप्ति जी आप कंटिन्यू करिए। यस।
हाँ सर, okay. Okay. So to start with varicose veins, I have given the caption as critical analysis of varicose veins. I felt like giving this caption because though it looks a simple topic, yet many things to learn in this topic. So critical analysis in the sense like I have tried to compile maximum information and made a comprehensive study by referring many of the books which I had with me. So just a note on it. So let's start with the definition of this. So varicose veins is permanently, each and everyone please concentrate on that, permanently elongated. So usually we read it as elongated, tortuous, dilated. This is what the words you know. So usually you will not be like permanently word pe aap dhyan nahi dete ho, like usually. So this is what how your definition has to start. It is permanently elongated. Okay, permanently elongated, dilated vein or veins with tortuous path causing pathological circulation. So usually these varices, that is what we call them as varices. So they are dilated, that means they're expanded below, above the normal range, what that vein diameter has to be. And elongated means the length of that vein is increased because of the loss of elasticity there. And it is a permanent problem. That is why when the patients come to you and ask, ये क्योर हो जाएगा क्या इतना मेडिसिन लेने के बाद, कैन यू क्योर अस करके? So you have to be very frank enough to tell that no, it's not a permanent cure. We can definitely get rid of your symptoms and treat this condition. So that is why the word permanently elongated is there here. Tortuous means, tortuous word here means where there are a lot of, when you have seen this case of, I think every one of us have seen lot of cases of varicose veins. So when you see the veins actually in this region in the lower limb, you can see some of the spiraling of the veins or twisting of the veins there. Lot of twists and turns are there in this veins. So that is what the word is known as tortuosity. So tortuous, elongated, dilated, these are the three main words for referring to the varicose veins. Then there is reversal of blood flow through its faulty valves. So because the valves are faulty means they are not having a proper venous drainage. Venous circulation is abnormal because of the presence of the incompetent valves. Because the valves are not functioning properly, blood flows, reversal blood flow is there. So once there are valves are not competent enough, then these veins get twisted and elongated in the natural course. Then what are the main risk factors or the causes to get this varicose vein? So one can be a hereditary factor or a genetic factor. Another may be a female sex. So specifically they have mentioned here. So sex-wise, the gender-wise, it's more in females compared to that of the males. Prolonged standing, those people who stand for a long time. Immobility, and another eccentric here is the prolonged sitting. If you are standing for a long time, also you will suffer with this. If you are sitting for a long time, also you will suffer from this. So both are not good. Raised intra-abdominal pressure. Okay, like in sports persons, one who is very much wearing this slim fit dresses or tight clothing. Okay, and in pregnancy, these cases, naturally the intra-abdominal pressure will be raised. So once the intra-abdominal pressure will be raised, automatically you will experience this twisting of the veins in the lower limb, giving rise to varicosity in future. So pregnancy may, why? Because it is because progesterone levels will be increased. That is the reason to get this varicose veins. And then one who is suffering from chronic constipation. Again, there is intra-abdominal pressure is increased in this case. So chronic constipation one who is having, then also he will end up in having this. And high heels. So women wear high heels. I don't think men can do this. So right from a teenage till the elderly person will wear very commonly the steel chappals, wedges, etc. Whatever we wear in our day-to-day life. So maybe that is the reason the female gender is highlighted in the risk factors. Next. This is just a diagram. You all have seen this, but still as a presentation, I have to put the diagrams. I have put the diagrams. So you look at both the diagrams. So you will see the twisting of the veins. Veins are twisted. There are various twists and turns are there. That is what is known as tortuosity. And look at the course, abnormal course of the veins. Veins are not like this. They have taken an abnormal curvature and a path there. Okay, elasticity is lost. That is why they look elongated. Okay, both are the same cases. Prevalence. What is the prevalence or incidence? It is 35% of the incidence. This is what I found in the book, but now practically when we go through in our practice, I find it is increased more now. Maybe another 10 or 15% you can increase. So because I feel it is more in my OPD, Shalya OPD, so many, it like fever, cold, cough, I'm seeing this varicose veins day-to-day basis. So I feel that prevalence has to be increased here. So severe varicose veins is 10%. Yeah, that may be agreed. Chronic venous insufficiency may be 8%. That what I have given here is what is the direct prevalence of having a varicose veins? It is 35%. So what is the severity of having a varicose veins? Means before it is becoming an ulcer, then it can be 10%. If a person is having any chronic venous insufficiency disorders, then it can be 8%. Chances are there to get this varicose veins. And if a person is having this venous ulcer, then there are 2% chances. So this is the incidence that they have given causes wise. Okay. So then let's go to the classification. So in classification, we classify normally on these three bases. Okay. One is great saphenous vein varicosity, small saphenous vein varicosity, and another is perforator varicosity. So here basically in the lower limb. So if in first year when you have done the dissection, if you have seen that, basically we have three important veins. The first most important longest vein in our body is known as the great saphenous vein. Okay, so that you have seen the starting point of that is on the medial malleolus, right? So it starts on the anterior aspect of medial malleolus, then it goes up and finally it is going to join with the femoral vein. So that means your entire leg it is there, right? So that is great saphenous vein. Small saphenous vein, yes, there also the varicosity can be seen. Another is perforator incompetence, means the varicose veins can also happen because of this perforator incompetence. That means to say when there is joining of the superficial veins with the deep connection, deep veins. So then there arises a term known as perforator. So these kind of perforating veins or the communicating veins, when they become tortuous, then we call that cause as the perforator incompetence. These are the three main, whatever may be the types of varicose veins. So don't worry about that. Whatever may be the type of varicosity, they have to come under these three categories. Okay. Suppose you have heard it as tibial, post-tibial, ankle perforators, etc. So it may be that, but finally they are given as tributaries from either from the great saphenous vein or from the short saphenous vein. Okay. So they are given, the words you can use are popliteal, okay, tibial, post-tibial, ankle. So different perforators are there in different regions, knee, above knee, below knee. So all these words what you are using, they are directly or indirectly the tributaries given out by great saphenous or by short saphenous vein. Okay, so that is why any type has to fall under these three categories. So now, just I want to drag your attention in this. See, just to remind you, anatomical parts, small saphenous vein, so where it courses. Popliteal vein is there exactly in the calf region at the mid, almost a little lateral to the midpoint of the calf region. Another is saphanopopliteal junction. This is one of the common points where you get the varicosity. And we have also clinically seen the cases where the people will have tortuosity in the saphanopopliteal junction. This is the point of communication. Okay, we get a vein called known as communicating veins, group of veins that are known as communicating veins. There are a group of perforators here. That is why perforator incompetence is very common in this saphanopopliteal junction. So above we know that is there is femoral vein. Okay, so in this small saphenous vein starts as a superficial vein. Finally, when it is draining into femoral vein, that is known as the deep vein. Okay, in between communicating them are known as perforating veins or the communicating veins. Now the other part, there is great saphenous vein. Okay, great saphenous vein also starts as superficial vein, and again when it is going into and draining into the femoral vein, it is going into a deep fascia or a deep system. So in between the great saphenous and the femoral, above and below, whatever you get, they are known as again perforating veins or communicating veins. Okay, so that means with this, what you understand is either you can get the perforator veins above the level of the knee, or you can get the perforator below the level of the knee. Doesn't matter, because the course of the great saphenous vein, if you see in this diagram carefully, is there from the beginning part of the dorsal part of the foot till it is going to join with the femoral vein. So because of this reason, you can get the perforators either above the knee or you can get it below the knee. So this simple diagram helps you to get lot of knowledge about the site and the names of this perforators. Moving to the next slide. This is second classification. First classification is depending on where the varicosity will be seen. Okay. Second classification is depending on the diameter or the dimension of the varicose vein that is going to happen. So I think you know these things. Thread veins. First we call them as thread veins. So initially in the initial stages of the varicose vein, okay, so they present as small varices usually found around the ankle that look dilated, red or purple network of veins. Okay, so this is what in the beginning stage when they come to you to OPD on OPD basis. So first they show you is near the ankle joint. इतने दिन नहीं था, आजकल इतना ये color change हो गया है. It looks red, it looks purple. They will not tell the color, but they will show you the site at the point of ankle. They will show you. There you can observe this red or purple streaks. Okay, so when you see, again the size is 0.5 to 1 mm. So it's very small in size, though it is small in dimension, but yet you can see them very clearly. Okay, very clearly you can say. So that is why they have given the name as thread veins, just like the size of a dimension of a thread. Okay, so by measuring the dimension of the thread is very difficult. So that also may be around 0.5 to 1 mm. So these dilated varicose veins at the level of the ankle also look of the same size. Okay, and these have different names. So in some books you might have read these words: dermal flares, telangiectasis, spider veins, hyperveins. So sometimes some of our students, interns, even PG scholars, they get confused. अरे इसमें दिया है dermal flares, spider flares, thread veins, reticular, सब same है क्या? Like yes, they all are one and the same. Thread veins, dermal flares, telangiectasis, and spider veins, hyperveins, all are having the same terminologies, same synonyms for the thread veins. Please remember this point, especially for PG scholars and these people. And the next to this thread veins, when the diameter slightly increases in size, say about 1 to 3 mm in size, when it becomes 1 mm to 3 mm in size, then they look little more larger and prominent than the thread veins. So again, they are located in the subcutaneous. Very easily you can see this, visualize this, right? Subcutaneous or subdermal region. So this is the next phase of the varicose veins known as reticular. Reticular, basically the word means which looks like a mesh or which looks like a network. Okay, reticular means. So the appearance will be exactly like that. So this is little next step of the thread vein. Last, it will manifest as varicose vein. So basically very, very prominently, very clearly, you can see all the superficial veins elongated in the subcutaneous area. So beginning from the saphenous compartment. So they may be either 3 mm in size or they may be more than 3 mm in size. So when you measure in the standing position, then you can get the actual size of that. So this is the last when it is going to become the varicose vein. That means to say the precursor of the varicose veins are in the form of thread veins and reticular veins, initial phases, and later it becomes varicose veins. Okay, if negligence is there, or because there are no symptoms, if the patient has neglected, or if the patient has not lost his or her weight, then because of those very reasons, person can turn into having the varicose vein. Last is combination of any of the above. That means to say, maybe at the ankle, he may be having thread veins. Little above, he may be having the reticular vein. And above the knee and posterior compartment of the thigh, he may be having the varicose vein. He will present all the three kinds. Okay, because of the pure negligence. Usually this fourth point what you have seen combination, that is purely because of the negligence. They will be knowing that they have some discoloration, but they will wait till any symptoms come. They will not go to the doctor till then, because pain nahi hai, dard nahi hai, inflammation nahi hai. They will think all these things. Why to simply go? Okay, so there is pure sheer negligence से आने वाला है. I just shown you some diagrams. See here. This is how is the spider vein beginning phase. So just small thread like change in the color from red to purple, red and purple. Next to that, I have marked there as reticular vein. So it is like mesh-like structure, and little size is larger than the spider vein or the thread vein. And further, this one again below diagram you just see spider veins I have marked red or purple, and reticular vein little more clarity is there. Now you see the last diagram. These are pakka the varicose veins, which you can see them much more prominent in size. Okay, see this is again varicose vein. Okay. So this is another way of classifying depending on the diameter of the varicosity. So two basic classifications. After that, I have mentioned some keynotes. So these are some words which we get in the scanning report. When you do a Doppler study, you can get some of these words. Okay, if you don't get these words also, clinically also, you can write in diagnosis varicose veins, whether it is bilateral or unilateral. Okay, chalo, you are written bilateral. In bracket, you can even mention these causes, whether it is atrophic Blanke, whether it is because of pulsatile varicose veins, whether it is because of Safina varix, etc. These are the different ways of presentations of the varicose veins. For example, atrophic Blanke. This is localized white atrophic skin surrounded by hyperpigmentation and dilated capillaries. Blanke is the word which is mentioned for something that is white in appearance. Okay, so some part of the lower limb will turn like a white patch, looks like a white atrophic shrunken patch like structure. So that is known as hyperpigmentation. I'll also show you the diagram here. See, in this diagram, first two diagrams, what I have put there, they are the typical cases of atrophic Blanke. So usually we have seen such cases, but we might have not thought about this word so far. Okay. Okay, not all I'm telling, but at least, yeah, some of us might not have noticed this name as such. So atrophic Blanke. First two diagrams, they look like a hyperpigmented white patch like structure, typical. Okay. Second is something known as Safina varix. Okay, Safina here refers to something related with the saphenous junction. So usually this will be seen as a prominent swelling. Okay, it will be seen like a gulma, or it will be seen like a prominent swelling where, especially in the groin region. Okay, in the groin region, a small mass-like structure will be presented, especially when he stands. Okay, when he stands or in standing position, it will look very prominent. Again, when he lies down on the bed, it will again disappear. Okay, so that typical presentation, we call it as Safina varix. Okay, so it may be small. If it is a small Safina varix, then the diameter will be less than 4 mm. If it is a large Safina varix, then it will be more than 4 mm in size. So this is the difference you have to know when it is called as small, when it is called as large Safina varix. And basically, as I mentioned, the site of the Safina varix is in the groin region. See at this diagram, at the groin region, you can see it as so much prominent mass or swelling like lump-like structure. Okay, and when you tell him to stand, it looks much more prominent. Okay, on lying down, again it will disappear. Next, one more way of presentation for this is corona phlebectatica. Phlebect means anything related to the vein. These are blue veins on the medial aspect of the foot. Okay, below the malleolus, around the ankle region. So what you are understanding is, so it will be around the ankle region. Again, where in the ankle region? Again, it may be in the medial malleolus or the lateral malleolus, but it is always below the level of the malleolus around the ankle joint on the medial aspect. So on the medial aspect means, again, it is pointing towards the medial malleolus. So just below the level of the medial malleolus, around the ankle joint, you can see some blue telangiectasis. That means blue, dilated, elongated vein elongated vein-like structures. And when you measure the size of this, these are usually greater than 5 mm. Okay, so these are the best independent predictor of the skin changes. So more than varicose veins, these are, isn't it? So they are more than varicose veins. So more than 5 mm in size when you measure them. Okay, so I have taken, see this diagram like this. When you measure this, either it is there below the level of the medial malleolus, and like this spots so commonly we have seen in our clinical practice. So, but still I want to throw a light on this word, corona phlegmoptactica. We have not, might be we have not so much seen or gone through this word, corona phlegmoptactica. Okay, so this is the typical presentation. When you look at the dimension, it will be measuring more than 5 mm in size. Last is something known as pulsatile varicose veins. These are very, very, very rare condition. This is a very, very rare condition, pulsatile. Okay, so this is seen in Klippel-Trenaunay syndrome. So Klippel-Trenaunay syndrome is basically a congenital vascular disorder. So it's very rare. Basically, this deformity, this congenital vascular deformity itself is very rare. That is why the incidence of pulsatile varicose veins is also extremely rare. Okay, so this is basically a rare congenital deformity in which the limb that is affected is having birthmarks in the form of red and purple veins. So again, the occurrence is in the lower limb. So by that is the birth defect. So by birth only, you can see wherever there are veins in this lower limb region. So they are presenting as red or purple birthmarks. Okay, red or purple birthmarks will be there, and usually there will be bleeding from that site. Severe pain can be felt. Bleeding will be there from that prominent varicose veins where they are there, and limb may be little larger also. Sometimes even the limb may be little larger and warmer also. The temperature may be changed a bit. So when you touch and feel that, so it may be a little warmer in appearance. So just a small introduction on that syndrome, Klippel-Trenaunay syndrome. So once of first of all, very rare, and there you can see the pulsatile volume. That means when you check the pulse there, so it will be pulsating in nature, and they say that clinically you can see that actually like that. Next is, so these are the keynotes or the words I just wanted to throw a light on the perspective of varicose veins. Coming to the last classification. So we discussed two classifications. Last classification is known as CEAP classification, CEAP, CEAP classification, where C stands for clinical signs, E stands for etiological classification, A stands for anatomical distribution, P stands for pathophysiological dysfunction. So very easy to remember this. Clinical signs means as a physician or as a Shalyagna, what is the dimension of the, or what is the diameter of the varicosity? Looking at the diameter or looking at the symptoms, you can grade them from 0 to 6. If it is very mild like thread vein, okay, let us give it as 0. If it is reticular, let us give it as 1. Means along with that, you should also consider the severity, like mild pain, moderate pain, severe pain, that also. Any inflammation is there or there is no inflammation, that also you have to consider. Okay, is there any thrombosis or not, that also you have to consider. So if none of these are there, then give it as 0. If slightly these things are there, then give it as 1. If there are reticular veins along with the moderate amount of symptoms, give it as 2. Like this, it goes on, increases till the level of 6. Okay, so usually 6 will be like complicating problem. Okay, E is etiological. So look for the etiology or the cause for which varicose veins is predicting as a reason. So it may be again congenital. So as I told you just now in this syndrome, okay, KT syndrome, that may be a reason. Primary because of the obesity also, for example. Secondary because of DVT also may be an example. No venous etiology. So rule out what are the causes and then consider it under etiological classification. Another is anatomic distribution. Okay, so anatomical means just now I have shown you the diagram. See whether it has affected the superficial vein or whether it has affected the deep vein or whether it has affected the perforator or the communicating vein. Look at the site, whether it is in the thigh region, whether it is in the anterior compartment, whether it is in the posterior compartment, whether it is above the knee, below the knee, above the ankle, below the ankle, or behind the this one, I mean the calf muscles, I mean in the region of calf muscles. So these are all the localities or the sites where we are seeing this persistence of varicose veins. So these come under the classification of anatomic distribution. Last is pathophysiological dysfunction. So what may be the problem? So usual thing is reflux, because as I mentioned before, the reason is there is no proper, because of the faulty valves. So there is blood flow is not happening properly. Venous blood flow is not happening properly. So that is because of the change in the reflex. And obstructive. Suppose there is some blood clot. Suppose there is some thrombophlebitis. Then that comes under obstructive pathology. Then for both, if there is a problem with the reflex, or if there is problem even as a DVT, then you can mention it as both. So basically these come under pathophysiologic dysfunction. So in Ayurveda, what can you take this for? You can use this parameter for writing the samprapti of this varicose vein. Okay. So this is the latest classification which they are using for classifying the varicose vein. Next, predisposing factors. Age matters, sex matters. Okay, race matters. Obesity is actually point number 1 in this generation. Okay, so initially they were pointing towards the female obesity. Now there are equal number of males who have the central obesity, and because of lifestyle changes, men and women are equally there in this factor as obesity. Height, those who have a short stature are easily prone for this. Okay, and left is more than the right. This till now I have also not got the answer for this. They always say left varicosities are more always on the left side than on the right side. I got this point only in one book, but I tried to search why it is so. Still I couldn't get the answer. If any of you know about this, please let me know about this at last. Occupation. Why occupation is necessary? You tell your students or the interns to note the occupation. While taking the history, you also consider occupation as one of the important parameters. So for example, long-standing people. So bus driver, bus conductors who are there. So bus conductors, we teachers who are teaching every day in our colleges, right? So we are active people who are more prone to get this varicose veins. And if we are obese, or if we develop obesity in future, again we are the victims for this. Other than this, long-standing barbers, you have seen barbers, police officers. So all long-standing job professionals are prone for this. Family history, as I told, genetic history or obesity. And erect posture, those who don't maintain the erect posture, or those who have the scoliosis, lordosis, all these anatomical postural deformities, such persons can also be suffering with this in future. Apart from this, what are the sites of varicosity? So now only thing that strikes to your mind is lower limb varicosity. They are there in the lower limb also. Other than that, you can also see them in scrotum, isn't it? So when you see this varicosity in the scrotum, what do you call it as? You call it as varicocele, isn't it? And sometimes it can be even seen in the perineum, vulva. Okay, arches, what we saw in arches, that is basically nothing but varices only, isn't it? That is basically the varices in that area. That's why perineum. Vulva also you can see. And in the scrotum or in testis, pampiniform plexus come in the testis. So there also you can see the varices. Other thing I have to mention, I forgot to mention, there is esophagus. Even there can be varices in the esophagus also. So varicose means it is not only concerned for the lower limb, it is also concerned with these different sites. Okay. Next, I have put one question on my own. Why varicose vein is more common in lower limb? Okay. So this is the frequently asked questions by all the students. So why it is more common in lower limb? Why not in the other places? This is the answer. Due to the erect posture and long column of blood has to be supported, that can lead to weakness and incompetency of valves. So that is the reason that there is lower limb has more, it's more prone for varicosities. One is erect posture. Okay, long-standing erect posture one cannot maintain, and whichever veins are seen, whichever veins you see, they're basically lengthier, elongated, and long column of blood is there. Long column of blood will be there to support these particular veins. So when that is not there, because of those predisposing factors, when these long column of the blood are disrupted, when they are disrupted, then that support will be lost to the valves. Once the support to that valve will be lost, then it leads to weakness and valvular incompetency. Once the incompetency develops, then there is reflex. Once there is reflex, then there are these changes, anatomical changes like tortuosity, dilation, elongation permanently in this. So that is the reason it is more common in the lower limbs compared to the other sides. So what is the incidence? 5% of the adult population. Then let us now see the primary causes and the secondary causes of the varicose vein. So what are the primary causes? One is congenital incompetence or absence of valves. So this absence of valves, we call it as avalvulia. The word used there is avalvulia. And in anatomy, anything which starts with A. So it says that it is the absence. Okay. Agenesis means there is no formation. Okay. Similarly, avalvulia means there is no presence of valve from the birth itself. So that is also a reason here. Second reason is weakness or muscle wasting. Who have a lot of muscle waste or weakness in the muscles, basically who built is very lean built or like malnourished built. So they can also go into this. And stretching of the deep fascia. Stretching of the deep fascia is because sometimes because of this any injury or because of too much of obesity, there might be the stretching of the deep fascia. And there is inheritance. As I mentioned, inheritance or a genetic factor. So there is a gene known as COX-C2 gene. COX-C2 gene. So this is a gene which is going to affect if the reason is familial background. Another one, as we learned, is KT syndrome, avalvulia, Parkes-Weber syndrome. Parkes-Weber syndrome is also basically like this KT syndrome only. Again, it is a congenital disorder of the vascular system. So this is also extremely rare. This is much more rare than that KT syndrome. Okay. Almost the presentations are same as that of the KT syndrome. Like as I told, there are red to purple birthmarks will be there in the lower limb. And along with this, one added thing what will be there here is, we call it as hypertrophy. So usually in this Parker-Weber syndrome, if you see both the limbs, one of the affected limb will be overgrown. So because of this overgrowth of one limb, there will be hypertrophy. Hypertrophy in the sense here there will be excessive growth of that particular bone and the soft tissue. Whichever limb is affected, that particular limb is overgrown. So because of that overgrowing limb, there is hypertrophy. That means in that region, whichever bones are there, whichever soft tissue is there, there is extra growth of that particular bones and the soft tissues. So this is one of the difference between that KT syndrome and this PW syndrome. Other than that, there are multiple formation of fistulas, AV fistulas. AV means arteriovenous fistulas. So that means abnormal connections. They are basically the abnormal connections between the arteries and the veins. So this is again congenital malformation. We can call it as congenital malformations of multiple AV fistulas. This is also an added information for Parker-Weber syndrome to differentiate it from the KT syndrome. Because if you go through the signs and symptoms, they look one and the same. You can so many times get confused or get mistaken for that. So just to get free from that, two things you can observe is, one, you can observe the hypertrophy, and another you can observe is the multiple AV fistulas. When these two things are ruled out, then you can confirm it as somewhat like PV syndrome like that. Hence, varices are of atypical distribution. Next, what are the causes of secondary varicosity? So why this can become secondary? So initial slide, what I have shown was primarily. So how it can be primary. This is how it can be secondary. So secondary main reason is recurrent thrombophlebitis. So this also we have seen in our practice so many cases, thrombophlebitis cases. So recurrently, if the person is suffering from thrombophlebitis, as a secondary, as the age advances, he can land up in having this varicose vein. That is one thing. Occupational history. So occupation, as I said, prolonged standing, traffic police, guards, sportsmen, conductors, teachers, etc. In these people, you can't tell them to change the profession, isn't it? Provided it is possible. You can't tell them. And people who are even traveling more for a very far distance frequently. Okay, it is very difficult that they can change their profession. Okay, so occupational, though it is a very important one, it can lead to secondary varicosity. It's very difficult to change the profession, even though you advise it. For you, advising is easy because actually in person it is difficult. Other than that, if there is obstruction in the form of abdominal tumor, retroperitoneal fibrosis, lymphadenopathy, ascites, if these are primary causes, then there can be chances of having varicose vein. If any abdominal tumor is there, what will happen? Intra-abdominal pressure will be raised. So because of that, again, there is extra abnormal pressure created on the lower limbs, isn't it? Because of that, there can be varicosity. Retroperitoneal fibrosis, certainly you understand this. Lymphadenopathy is a general cause. Ascites, again, intra-abdominal pressure is raised in this condition. Other than this, pregnancy, as I said, that there is an alteration in the progesterone-estrogen ratio. Because of this alteration, there will be built of this varicosity. But they say that if this is temporary, so after pregnancy, this starts little fading away, provided she reduces the weight and keeps the things in normal condition. So they say that it disappears, or disappears in the sense it starts fading away. It will not be that much to what it was presently there at the time of pregnancy. Okay. Another is AV malformations. Just like I gave you an example of multiple AV fistulas. So if it is congenital malformation, then also it can lead to secondary varicosity when the child grows up. Then iliac vein thrombosis. This is one of the very crucial reason I can tell. The persons who are suffering from DVT, with DVT, when you do the Doppler and see the DPT where the site is, so I have 4 cases where the patients will be having, in the scanning, changes will be noted as iliac vein thrombosis. So usually the clot will be there. It may be unilateral, again it may be bilateral, doesn't matter. So usual cause for DVT is at this site, iliac vein thrombosis. And because of this, again it can lead to varicose vein. After this, tricuspid valve incompetency is there. That also can lead to varicosity. So we should be clear enough in degrading, like knowing which is this primary or is this secondary cause. Because until and unless you know it is primary or secondary, your treatment will not be successful. Because if it is a direct cause, then you treat the varicose veins directly, correct? If it is a secondary cause, then you should always try to find what is the actual cause. So then you have to treat the actual cause, not the varicose veins there. Okay, so if you're doing ulta, then you will not get the result. So that becomes crucial to know whether it is a primary one or a secondary one. And these are the usual symptoms when you ask in patients when they return to your OPD. They will have dragging kind of pain will be there. Postural discomfort. They cannot sit for a long time. They cannot walk for a long time. This is the discomfort. Heaviness in the legs. People who are obese, this is the symptom or the complaint they come with. Nighttime cramps. Usually when you ask, they will tell in the calf region, especially in the calf region, they will feel lot of heaviness and dragging kind of pain, especially in the late night. They will specify this when they come to you. And then in obesity, again, you can see the edematous feet. Edematous feet. So usually when you examine, again, they may be even having the pitting edema also in that. And severe itching may be seen. Kapha prakriti individuals, if they're chronic diabetic, this is also one of the complications that can happen. Severe itching can be seen in those people. And discoloration is common because that is one of the presentation. Ulceration in the feet or painful walk. So ulceration is actually more than a symptom, it is a complication. Okay, it is a precursor of this varicose veins is what I can say. Clinical signs. I think I will not go into detail about this. You know about this. So just it is the recap for you. Okay. Brody Tenderlin birth test. In this, there are 2 things, 1 and 2. So just I can tell you here. So this is how it is done. So try whichever limb is affected, you tie a tourniquet there at the level of the this one, saphenofemoral junction. You have to tie the tourniquet, and when you elevate, so there should be filling of the blood. So for example, when you elevate or tell the patient to stand up after you have tied the tourniquet, if you're seeing the filling up of the vein from above, then you take it as the incompetence is in the saphenous junction, SFJ. SFJ is saphenofemoral junction where there is incompetence. That means to say above the knee. Suppose you try a tourniquet below the level of the knee, and when you tell him to stand again, if there is blood flow, if there is filling of the vein from below, then it is usually the SPJ, cephalopopliteal junction mein there is incompetence. Like this, you can clinically judge where there can be a chance of incompetence. Okay, so this helps you to determine the site of incompetence where it can be before you send for a Doppler. Okay, because every person is not affordable to do these kind of investigations, because varicose veins में जो भी investigations है, जो भी treatments है, the person cannot. If a labor person comes to you, will you send him for the Doppler? No. You have to be smart enough to see the clinical signs, symptoms, do these tests, and confirm the diagnosis and give him the treatment. 2,000 rupees where we will have if you send for a Doppler. Okay, so thinking from that perspective, so even though until and unless in my practice, I find that it is going to turn into DVT, or if I have a doubt of suspension for DVT or thrombophlebitis, only I'll send for scan. So otherwise, 97 to 98% of the time, I will not send for the Doppler test. Either he may be a rich person or he may be a poor person, because we are doctors, we are Vaidyas, so we have to have that medical ethics. Investigation लिख दो, जो भी है लिख दो. No, we shouldn't. I personally think we shouldn't do that. As long as clinically we are good, clinically we are sufficiently knowledge, so better not to send for the investigation. So as long as possible, try to avoid this. Next test is something known as 3 tourniquet test. 3 tourniquet test. So you can see in the diagram, at the level of the knee they have tied a tourniquet. Above the knee they have tied a tourniquet. Below the knee they have tied a tourniquet. So again, when you tie the tourniquet here, so when you release the tourniquet, then observe for a few seconds where the blood starts filling. So again, if it is going to start filling from above, between the knee and the upper part, then you think there is a perforator incompetence in the adductor canal. Okay, if there is sudden blood flowing below the knee and in the region, in the anterior part of the thigh, then you think there is perforator incompetence at the level of the knee, below the knee. And again, you do this work, and again, if you see the filling of the blood from below the level of ankle, definitely think it as there is an incompetence at the level of the perforators which are located at the ankle. This is the easiest method and the safe method to do this. Within few seconds, you will be able to note the site of the incompetence. So above, if it is above the knee and between the thighs, it will be adductor canal, perforators are involved. If it is below the knee, above the ankle, then it is below knee, perforators are affected. If it is around the ankle, definitely ankle perforator incompetence is there. So like this, we can take the help of these tests and understand. One more thing we do is Schwartz test. So in standing position, see, they have shown so clearly. Tap the lower part of the vein. Impulse is felt on the staphenofemoral junction. So above where he is holding the hand, above in the upper part, where there is GSV. GSV is great saphenous vein, where it is there at that side. Okay. So first he is tapping on the lower part of the vein. Okay. He is tapping at the lower part of the vein. When he presses or taps that part, suddenly if he gives a jerk in that region, that the impulse will be felt on the staphenofemoral junction. This is also an easy method to find out where there is incompetence. Okay. So this is an easy test known as Schwartz test. Next, one more such test is there, that is known as Perthes test. Okay. So again, what you do is you empty the Vitelline to standing position. Tourniquet is tied around the thigh. Patient is made to stand. Around the thigh, you tie. Ask them to rapidly stand up and down on their toes. Means on the toes, up and down. Like when you do the stretching exercise, up and down, up and down, up and down. Yeah, like he has to do it continuously. So when he does this, then if there is filling of the veins, okay, continuously when he does this up and down on the toes, then suddenly if there is rushing or the gushing of this vein, then definitely it indicates there are competence, valvular incompetence is there in the deep vein. This is mainly to find, this Perthes test is mainly to find if there is valvular incompetency in the deep vein. Okay, in the deep vein. So that is why this is done. It may be little painful, but not that painful. So little, because he has to do continuously, little up and down on the toes he has to do. So when he does that, actually you can see that gushing of the blood. So if you notice that then definitely the deep veins will be affected. If you are not seeing that, then this test is considered as negative for varicose veins. Okay. So these, what I have told, this is what I have written in the slide: 3 tourniquet test, Schwartz test. Another test is known as Stevens test. So Stevens test is also mainly done. So standing, the site where perforatus enters the deep fascia bulges and is marked. So here again, when you tie the tourniquet, so deep fascia will bulge. When you tell the person to lie down in the lying down position, you can free a half moon shaped structure in the deep fascia. Okay, marked out points which confer it. So this is usually below the level of the knee. Usually below the level of the knee. Crescentric shape, what they're giving is, usually you will see there, when you release the tourniquet or when you make him to lie down, you can see a depression in that area, which looks like a crescentric shape. So in the deep fascia, this is also again to look for the deep veins. So a pressure or a pit like a depression like thing is created when the perforator incompetence is there. So perforator incompetence is again when there is a communicating vein is damaged or becoming incompetent. So this is mainly to see for perforating incompetence, which one? Stevens test. So like this, we have 3 to 4 clinical tests which can actually help even us, even for them. Okay. Last part is complications. So one basic complication is venous ulcer. Next is having the hemorrhage. Hemorrhage can be there as a complication because that area will become sensitive as we advance age by every year. So once we advance by age, so any small blowout or any small blunt injury may also cause the hemorrhage in this area. Then pigmentation, what we call it as hemosiderosis, that discoloration or pigmentation, what the color change is there, that we call it as hemosiderosis. And then eczema can be there. Eczema can be there. Dermatitis can be there. So these are the complications, usual complications. Other than that, venous ulcer can be there. Marjolin ulcer can be there because of unstable scar, because that scar will not go. Almost it remains for a lifetime. Ulcer. If the person had Marjolin ulcer, so where it is a non-healing ulcer once again, so in that case, this will remain as permanent thing, almost like a permanent thing. Apart from this, most common thing are DVT, recurrent thrombophlebitis. So these are the usual complications that we come across. Okay. And next, what are the basic investigations that we have to do? So at least basically we can send for CBC, ESR, okay, and then DVT, because DVT changes, we find some changes in the CBC, this one. So basic investigations, you can send them. And now we have the latest investigation as venous Doppler. So again, see that if you want to send for unilateral, write it as unilateral. If you want to send for bilateral, write it as bilateral. So see the affected limb and then decide to write the venous Doppler. So this will help you to assess many things. This will help you to rule out DVT, and this will tell you the site of incompetency where it has happened. Like as I mentioned, whether the incompetency is there at SFJ. SFJ means stephano-femoral junction, or if it is there at SPJ, stephano-popliteal junction. Okay, this is one thing. Second thing, it will also tell whether there is incompetence in the communicating vein or not. Okay, so if that is the case, then whether it is in the adductor canal, whether it is below the knee, or whether it is in the ankle region. So it will also tell you the site. Apart from that, it will also tell you the thrombus, whether there is formation of thrombus or not. Okay, if they get any drought, so usually if there is thrombophlebitis, Doppler will help you. But if it is a deep thrombosis, then usually they will advise you to send for MRI, further higher investigation like that. But almost this will do your job. So just sending for a venous Doppler will actually do most of your job what you want for treatment purpose. Apart from that, we will send for USG of abdomen. So why USG of abdomen? If the cause is abdominal tumor, for example, if the cause is abdominal tumor, if the cause is fibrosis, so in this case it becomes secondary. Varicose veins will become secondary. Then you have to send for USG of abdomen. Peripheral smear, if the patient is very anemic. Okay, if he is very anemic, then you can even test this. platelet count, plain X-ray of the part to look for the periosteitis. So in this region, so here I have mentioned delays, healing of ulcer due to poor perfusion of ulcer bed. So periosteitis is the because of the ulcer, venous ulcer, the margins will heal very late. The margins of the ulcer will heal very late. First thing. Second thing, whichever bone is involved in that area, even that will heal very late. So periphery of that. Okay. So after that, you send for ascending phlebography, descending phlebography. So these are not done nowadays. So earlier days, we didn't have this Doppler as such. So now maybe more than a decade, we have this Doppler studies. So earlier when these things were not there, they were sending for ascending venography, descending venography. So what they used to do, for example, just briefly I'll tell you. So for example, if you want to send for ascending venography, means usually they will tie the tourniquet above the ankle. Above the ankle, they will tie a tourniquet and they will pass a dye. So once the dye is passed, so if it is deep veins are seen clearly, when the dye is passed, if the deep veins look very prominent, then the diagnosis is DVT. Okay, if the dye is not seen as such, then it is varicose veins. This was the easy investigation. Similarly, they were also doing descending venography. So that means they will insert in the femoral vein, they will insert the cannula-like thing in the femoral vein. But in this, you have to tell the patient to stand. Standing position में femoral vein का size locate करके, site locate करके, you have to pass the cannula. So once you pass the cannula, after that you inject the dye. Once you inject the dye in that deep vein, so that contrast material, tell him to sleep off. So once he lies down, you can see blood flow. This contrast material, dye what you have injected is heavier than the blood. So because of that, it may flow lower down in the leg. So once you see this dye prominently in the lower down in the leg, so it indicates that the valves are incompetent. So these were the basic investigations that they were sending, because at that time these things were not there. Duplex scanning, these facilities were not there. But nowadays, I don't think anyone will send for these things. Okay. Differential diagnosis. So again, which are the diseases that mimic with the varicose veins? Lymphadenoma will mimic, because lymphadenopathy will be there, which is secondary reason for varicose veins. So definitely this will mimic the condition. AV malformation in the form of multiple fistulas, and orthostatic edema. So sometimes due to obesity and short stature, both combined together. And if they have kidney function, improper kidney function, so edema also will become a differential diagnosis. Other than this, renal, cardiac, hepatic diseases. So definitely, because renal may, as I said, this orthostatic edema, that one. Cardiac may, if the tricuspid valve becomes incompetent, that becomes the reason. Hepatic, that is very much understood, portal hypertension, etc. things, if they're there, then that also becomes differential diagnosis. Other than this, gout, Vatarasta, what we call almost mixed edema, too much of obesity, should not be confused with this. So elephantiasis, so or cellulitis, so that also should not be confused with this. And chronic infections in the form of tuberculosis, syphilis. So these are the usual differential diagnosis in relation to the varicose vein. So now I have listed some of the conservative management. So it's not only writing Kaishora Gugulu, vein flexency, Pindatailam, like this. Okay. So after this, you should also educate the person to some of the things. For example, I usually tell them to wear a compression stockings, elastic stockings. So suitable size, which is suitable to them, they have to buy the stockings and see that throughout the daytime they have to wear it. Because some people's occupation is long standing, some people will have too much of traveling. Okay, so when if some of them are having arthritis also, etc. things, so it will actually give the support. Once it gives the support, then the valves, the lumen of the valve will be protected. Once the lumen of the valve will be protected, automatically the tortuosity will come down. So actually wearing this simple compression stockings will help a lot for the patient to get relief from the symptoms. So this is the first thing you have to tell them. So next thing you have to educate them is foot end elevation. Tell them to take 2 hard pillows and elevate the foot at the night time. They can do this also. So these are some basic education that you have to give them. And also you have to tell them for what you are telling that, to increase the blood circulation or to channelize the blood circulation. So try to educate them by telling these things. So wearing stockings will help to elevate a lot. And then apart from these things, conservative management, and then you write your prescription. And also please tell about the diet. Pathya Vichara, to avoid all Vatakara Aharas, Pittakara Aharas, they have to avoid this. And also Nidana Parivartana. If they're too much obese, then see that you tell those. And if they're uncontrolled diabetics, see that you control their diabetes again by telling the Pathya Vichara. So these are all actually, though they look small things, yet they are very important things or crucial things. So if all, in spite of doing all these things also, if it fails, then you go for the next thing like sclerotherapy or your ablation therapy, etc. thing. Sclerotherapy, what they will do, they will just, it's like giving an injection to the veins. Okay, so because of that vein wall, the lumen of that vein wall will get sclerosed, and thereby the tortuosity will come down. So these are the things which you have to keep it as the last resort if your conservative management will fail. Okay, and you can even try with our conservative management. Kashaya Dragyas, Mahamanjishtadi is good. Pindataila is extremely good. Sahacharadi is extremely good. Apart from this, this one, Mahamanjishtadi, this Ksharabasti we give, right? So that also works wonderfully. Ksharabasti. So that, or Kashaya Basti also you can give. Okay. So all this you can do in the patients. You can even give Snigdhagni Karma. So this is not told in our classical texts like Snigdhagni Karma, but I have tried this in many of the patients. Because when they come up with severe pain, some patients will come in such a way that they have sciatica as well as this problem, both together. So in that point of time, when they have come to you, your job is to immediately relieve the pain in him. So in that time, at that point of time, Snigdhagni Karma will help actually very nicely. So that is another way where you can do this. And Jalavka, in case of too much of tortuosity, so definitely go for Jalavka Vacharanam. It will give excellent results. So sitting once again depends on the severity. So for 2 sittings to pakka they will need, 2 sittings to compulsory chahiye. Okay. So after that you decide, see the progress, and then you decide for the further sittings. So doing Jalavka also helps a lot. Okay. So actually, as a preventive measure also, we can do this Jalavka Vacharana to prevent DVT in future. Those who are obese especially. So in that, even though it is a secondary factor, even though it is a secondary varicose veins, doing Jalavka will not cause any harm in them. Okay, confidently, aramse you can do the Jalavka in those people, so that at least they are prevented from thrombophlebitis or DVT in their future lives. Okay. If all these managements fail, then go for these big list of surgeries. Okay, here you know these things. I do not want to go in detail about this. So these are the usual surgeries that we have learned. Trendelenburg operation, vein stripping. They will do the stripping of the veins. Okay, so some part of the GSV is taken, and then will do the stripping of the veins. They will do the ablation. Okay, and gluing they will do. Okay, phlebectomy they will do. Okay, so only thing where they don't do the surgeries, if the person has DVT, definitely we cannot do the surgery in that case. Okay, so these are the different ablation therapies and the vein stripping method. Sclerotherapy, where sclerosants or injections are there pushed into that and relieve, pain is relieved. But another thing is this is, you still cannot assure the patient that it is permanent solution, because
Deepti ma'am,
this is,
Deepti
yes,
ma'am, Dr.
yes,
Deepti, प्लीज
yes,
मैम थोड़ा मैं डिस्टर्ब कर रहा हूँ बीच में, सॉरी, टाइम काफी
हाँ,
हो गया, तो प्लीज थोड़ा शॉर्ट में
okay,
हम सम अप कर लें
it's
इनको.
over, yeah, it's over.
हाँ हाँ, ओके.
Okay, okay. So last is some few
आप कंटिन्यू
references.
रखें, अगर हो सकता है तो शॉर्ट में कर लें, कुछ रह गया तो प्लीज शॉर्ट में कर लें थोड़ा बस.
Yes, yes. Okay. So these are some Ayurvedic references that I have got for Stira Granthi. So the Nidanas are Vyayama. Okay. So Ati Vyayama. If too much of Vyayama, then also it's a problem by weak persons. And if there is Vayurhi Stira Pratanam. So if there is excessive aggravation of the Vayu, then also it will cause Stira Granthi. And Samprapti is there. Just you can note these references. So Shruta Nidanasthana, 11th chapter, they have told because of the sankocha of the sira, there is severe pidana. Pidana means Vedana in that. Because of that, there is Vishoshana of the Rakta. Rakta gets vitiated and then it will give rise to tortuosity, which is known as Unnatanam Ashu Krutam, Vritam. So circular, elevated, Granthi-like patches. And this one is telling the Lakshana. So basically, this is Krishna Sadhya Vyadhi. It is difficult because definition only tells it is permanent. Krishna Sadhya Vyadhi, it becomes Asadhya if the Granthi is very large at the Marmasthana. So that is another reason. And just treat like the Shofava Chikitsa. So Shruta Nidana mentions that just treat like the Shofava Chikitsa. Yoga Ratnakara will tell about the Jalaukacharana. Okay, Shofava Chikitsa as well as Jalaukacharana. Yogas that Yoga Ratnakara has mentioned as Himsradi Lepa and Madhukadi Lepa. So from outside you can apply them. So this is the main thing. Charaka Chikitsa Sthana, also they have given the references. So what are these same things are the references. Okay. So these are the references that I have got from Surushruta, Charaka and Yoga Ratnakara. Nowhere else I could find the references. So I think too much of explanation. So thank you for patience listening.
थैंक यू मैम, थैंक यू सो मच। बहुत बढ़िया इन्फॉर्मेशन दी आपने। मैंने सभी पार्टिसिपेंट को भी अनम्यूट किया है। आप देखिए, अगर आपका कोई क्वेश्चन है, कोई सवाल पूछना चाहते हैं तो सभी वैद्यगुण से पूछ सकते हैं कुछ। आप अनम्यूट हो पा रहे हैं? देखिए एक बार। अविनाश जी, डॉक्टर गौतम जी, कोई क्वेश्चन है आपका, पूछना चाहते हैं तो पूछ सकते हैं। चलिए, कोई क्वेश्चन नहीं है। सो दीप्ति मैम, थैंक यू डॉक्टर दीप्ति, बहुत ही बढ़िया आपने इन्फॉर्मेशन दिया सभी को। बहुत बहुत धन्यवाद आपका। अभी शायद डॉक्टर गौरव जी कुछ पूछना चाहते हैं।
हाँ।
डॉक्टर गौरव जी बोलिए प्लीज, आप अनम्यूट हो पा रहे हैं क्या? मैंने सभी को अनम्यूट तो किया है। शायद अनम्यूट नहीं हो पा रहे हैं। आप अनम्यूट नहीं हो पा रहे हैं क्या? देखिए प्लीज एक बार। ओके, थैंक यू दीप्ति मैम, बहुत बढ़िया इन्फॉर्मेशन, बहुत अच्छी जानकारी दी है आपने। आयुष दर्पण पे आपने इतना अपना समय दिया, उसके लिए बहुत बहुत धन्यवाद। थैंक यू सो मच।
Thank you, sir. Thanks for taking more time. I didn't get to know. I also didn't see the time. Sorry for that. And thanks to Dr. Naveen Joshi, sir, who has given me a platform today to discuss on this topic. Thanks a lot, Naveen, sir.
थैंक यू मैम, आप इतना अच्छा बता रहे थे, रोकने का मन ही नहीं किया। थैंक यू।
Yeah, sir. Thank you. Can I log